Verapamil is a perfect example of how medicine is like a pendulum. Given enough time, you'll notice that some practices will swing back to the way they were a few decades ago. Some of us, like Redfield, were around in the late 20th century when it was first approved by the FDA and American Heart Association to treat AFib with RVR. On the other hand, if you started practicing medicine the last decade or so, your familiarity with verapamil might be limited to a paragraph in the cardiology section of your textbook. Because of unexpected manufacturing and production disruptions in diltiazem, we all need to refresh ourselves on this classic calcium channel blocker. Verapamil works by selective inhibition of L-type calcium channels, which can be found on smooth muscle and cardiac cells. The calcium blockade causes vasodilation, so you may anticipate a potential drop in blood pressure, and decreases heart contractility. By the same mechanism, verapamil also slows down conduction at the AV node, giving any aberrant reentry loops a chance to terminate. But how does this help in AFib? The AV node continues to act as a gatekeeper of electrical conduction, so verapamil helps to reduce the number of atrial impulses that reach the ventricles. This helps to treat the tachycardia, but doesn't treat the underlying rhythm. As you can probably see where I'm going with this, verapamil is a good option for chemical rate control of AFib with RVR, as recommended by the American Heart Association. Similar to diltiazem, verapamil is also a Class 2A alternative treatment for narrow complex tachycardias that are refractory to the traditional vagal maneuvers and adenosine. The administration is straightforward: 2.5 to 5 milligram IV push over 2 to 5 minutes, and you should start seeing peak effect around 3 to 5 minutes, and lasting 30 minutes to an hour, which is hopefully long enough for your transport, but you can give another 5 milligrams every 15 to 30 minutes as needed for a total of 20 milligrams. On the spectrum of interventions, how does this stack up when compared to our other tools for AFib? After looking at all the randomized controlled trials, the American Heart Association has concluded that verapamil is just as effective as diltiazem for the treatment of stable AFib with RVR. Like I mentioned earlier, it's great for rate control, but not so great for rhythm control. If you get deep into the nitty-gritty numbers, the results are weighted towards diltiazem, which may explain the shift in practice over the past few years. That being said, some of you may have heard of this drug being called Verapamil. How did something that's listed as a Class 1 recommendation by the AHA get that sort of reputation? It's not like droperidol, which was blacklisted by the FDA after they made conclusions from studies that weren't clinically relevant. On the contrary, the Verapamil moniker can't be traced to any specific case or evidence-based trial. If anything, it was the culmination of anecdotes by clinicians sharing their experiences over time. Was it truly the verapamil that caused all the poor patient outcomes that people talk about? From what we know now, these cases were, like everything else in EMS, multifactorial. If you look back at the older literature, you'll see that we weren't that great at interpreting cardiac rhythms back in the day. To try and make things easier, a lot of clinicians used verapamil as a sort of diagnostic tool, and some of those times happened in patients with undifferentiated wide complex tachycardias. Adverse events have also been documented in patients with severe CHF. The smooth muscle vasodilation adds stress on an already failing heart. Furthermore, on a milligram to milligram comparison, verapamil does have stronger negative inotropic effects as compared to diltiazem. And by decreasing the contractility of a weak heart, you're setting up a patient for cardiovascular collapse. This is why the 2023 AFib updates from the AHA added an important guardrail to their guidelines, and that is that calcium channel blockers should be used when an ejection fraction is at least 40%, with potential for harm in patients with moderate to severe left ventricular systolic dysfunction. Now, this specific recommendation doesn't translate perfectly to the field, since most of the time we don't know the patient's ejection fraction. But you can put together a pretty good idea by looking for a history of heart failure or cardiomyopathy, checking for an implanted defibrillator, and looking for the classic signs of a CHF exacerbation. These are the patients who you should be more critical about your resuscitation options. Verapamil is an old drug with a timeless lesson. Pharmacology is predictable. And if you know the pharmacology, you'll know why and exactly how this medication can potentially cause adverse effects in patients with a wide complex rhythm, a pre-excitation syndrome, or a severely failing heart. Conversely, you will also know exactly which patients can benefit from verapamil and how it can save their life. And that's all we have for this episode. This was a production of Redfield Medical Direction. This episode was produced by me, Lin Win. The theme music is by Infraction. As always, don't hesitate to reach out if you have any questions. See you next time.